All right, seems to be slowing down a little bit, so why don't we go ahead and get started. Welcome to the the August RightSleep Q A. We're thrilled you could join us, whether it is live here today or on replay. My name is Heather. I am Dr. Gomanak's assistant, and we have some pre-selected questions. And just a reminder about the questions, this is not designed to replace a consultation. So we're trying to ask general questions. Questions that Dr. Gomanak's answers will help more than just you, the multiple people. So that's the design of this. And please remember that these are exclusive benefits, this in the Facebook group, to purchasers of the RightSleep workbook. And if you're not a member of the Facebook group, it is facebook.com/RightSleep4U. And just answer the questions that pop up afterwards. This is being recorded, and your replay will be in the Facebook group and in your inbox, in your email, within approximately 1 week. And with that, I'm going to turn it over to Dr. Stasha Gomanak.
Thank you, Heather, and thank you everyone who is coming to this question and answer session. I want to let you know also that we now have 2 ways for you to make appointments. This is currently in transition. I'm not sure whether or not this will be permanent, but the current situation is you can make a half-an-hour appointment. This is for people that you're going to introduce to the program. You're going to make a half-an-hour appointment called a getting to know you appointment. If you have not bought the workbook and you just ran across one of my videos and you want to know more about the program before you take the first step, there is now a second appointment that is an hour that's called a RightSleep strategy session. I want to let you know that my optimum results in this program in terms of coaching are to sign up for a full year. And that is because things come and go. And it has been my experience that I really need to make appointments with you on a regular basis. And one of the reasons why it lasts a year and that I want you billed monthly is I want you to remember every time that credit card bill goes in that you've made a commitment to this program. You're paying for it for a whole year. You're going to work it for a whole year. You're going to actually direct your attention. You're going to journal. So it's a way to help you to stay on track. So I've instituted this new strategy session with the idea that if you really just need one visit to go over things, I want to provide that to you. But if it turns out that you really need email support and longer support, then I'm going to really urge you to sign up for one of the coaching programs. There is a year-long coaching program that starts with the beginning called Breakthrough Right Sleep. And then there is a 6-month program called Advanced Right Sleep. You have to be 6 months into Right Sleep to be able to sign up for the advanced program. Occasionally, people are sick enough that they may actually need 2 years of coaching. And I try to be flexible about that and how we design it so that it fits with what we think you need. Okay, now I'm going to let Heather go ahead and start asking me questions, but there may be some questions that are asked in a very detailed way about a specific individual, and it's really not safe for you or I to answer those individual questions as they're stated. I'm going to answer them in a general way.
Okay, so the first one is a little bit longer, a little more detailed. I began RightSleep in May of 21. I am one of the few that needed B100 during the first few months. Stopped the B vitamins when the protocol suggested and struggled to sleep worse than before I began. Then I started sleeping a little better until all my body was aching. I decided that was my cue to begin the 3rd phase. Slowly added Bs and started sleeping better, increasing pantothenic acid to 95. And the sleep became very disrupted, but I never woke without pain. I slowly lowered the Bs and still never woke without pain. I am now very slowly raising the Bs again. I stay at the same level until I start having more pain or disrupted sleep. I am at a pantothenic acid level of 60, but I still don't wake without pain. Still taking B50 and the multivitamin. Sleeping better, and my Raynaud's has completely subsided. Do you have any other suggestions?
Okay, I want to address this in a general way, but this is a very good question because I have put together this workbook to try to cover the most common occurrence for most of the population. But people who have been sicker longer or people who have been taking D for several years. So I want to remind you that I wrote this protocol based on what happened to me and my patients while we were doing something experimental. So I'm going to give that picture again, because then I put together some answers, but every single individual is unique. So remember that I and my patients were taking D of various doses to get a D level of 60 to 80 over a 2-year span. And at the end of 2 years, many of us were not that happy. I had this peculiar buttock pain where I couldn't sit down at the end of the day, very weird. Many of my patients were coming back and saying, my sleep is lousy and I ache all over, or I have inflammatory joint pain. I just saw a rheumatologist. They're having new things happen to them. They are taking D without correcting their microbiome at this point. And what I've actually done without intending to is that D has helped them to try to make acetylcholine, because D actually makes choline acetyltransferase be expressed. So it's trying to make your sleep better, but in the meantime, it's using other things. So one of the things that it must have is coenzyme A, which is what B5 becomes. And the other thing it needs is choline. So those two things, plus the enzyme that D makes the acetylcholine that makes you sleep better and also lowers the inflammatory state. I get into this not knowing any of what I just told you. What I get is a book. It says B5 is good for rheumatoid arthritis and it helps sleep. So I give out large doses of B5, doses that were the recommended dose. And what happens instead of what I expect, instead of coming back and saying, oh, this helped my pain and my sleep, 500 milligrams of B5, even when combined with B100, consistently made people come back and yell at me, which was very upsetting. Personally, it made my restless legs much worse. And the people came back and said, this stuff, this pantothenic acid, 400 milligrams, made me so agitated that I stopped it after 2 days. I felt revved up, agitated, anxious, and I couldn't sleep at all. That means that B5 has power in sleep, but it also means there's a dose effect. So at that point, I had stopped the 400 milligrams of pantothenic acid myself. I was on B100. It was the perfect dose for me. Remember, I have depleted my B5 stores badly enough that I have new symptoms that turn out to be B5 related. So several other people had things like burning in their hands and feet. That means I've pushed my patients into a new deficiency state by giving them something that uses up these other 8 Bs. What I didn't know at the time was they also did not have the normal source of 8 Bs, which is a normal microbiome. So as I'm giving B100, without really knowing it, I'm recreating the B vitamin soup that should exist in the GI tract if you have the 4 normal phyla. And I'm actually encouraging the 4 normal phyla of bacteria to grow back, because I'm now giving them D plus all 8 Bs, all the growth factors they need. And that, in retrospect, caused people's IBS to go away and their pain to get better. So most of us who were willing to go forward and didn't fire me took B100 and did fine. Now, what happened next was I thought, you know, when we started this, too big a dose made everybody worse, including me. If I'm right, once reading the B literature, and I say to myself, you know, if we're seeding these cultures of bugs and they all grow back, which is really what I want, because I don't want to have to mess around with these bees because they're scary, they hurt people, they hurt me. I don't know what the doses are. There are 8 of them. This is too confusing. Really what I'd like is to get the 8 Bs made in the natural way, which is from the 4 phyla of bacteria. what if adding these 8 actually gives them a bee soup, encourages them to come back, and then sometime in the future, we're going to have the production from the bugs. We're going to have the normal amount of 8 chemicals being produced by the bugs, plus the B100 that I'm taking. That's going to be a disaster because that's going to be double the dose, and everybody's sleep is going to fall apart again, and their pain's going to be back. So I start telling my patients, I'm thrilled that you're better on this B100. I'm hoping that it means that we're kind of coaxing the normal bacteria by giving them the cofactors they need. But that might mean that sometime in the future, your sleep is going to abruptly fall apart and your pain will come back. And when that happens, I need you to stop the B100. At the time, I had no idea whether or not I was right, whether it would really bring back the bacteria. But over time, it became clear that 3 months of a D that was now in range and B100 brought back the bacteria. And at the 4th month, which is where I started to fall apart again, at the end of the 4th month, I started to wake feeling old, achy, creaky, really stiff in the morning. And one of my patients who was coming in said, you gave me that B100 to take. She was only in there for headache. She did not have chronic pain. She did not have anti-inflammatory. She did not have an autoimmune disease. She did not have all sorts of other things. She had, you could say she was like medium sick. Okay, if I'm mildly sick, she's medium sick. The person who asked this question was severely sick with lots of chronic pain. The gal comes in and says to me, B100 made me ache all over. She started it. Immediately, she felt stiff and achy and old. And I said, oh, well, that's how I feel in the morning. And what's up with that? Why do I feel that way? Oh, is it possible my bugs are back and I've actually doubled my dose? So the next day I stopped the B100 and the following day I don't wake up in any pain. So I started to assume that people who were moderately sick, who'd only lost their GI tract source of the bees for a moderate amount of time, really needed to start on B50. So that became the routine. They start on B50 plus the multivitamin that has 10 milligrams of B5. So in sum, they're on 60 milligrams when they start. Now, if you've been on D a long time and you are profoundly B5 deficient, then you may actually need to move up to B100. Some people needed to move up even farther than that. And then there are some people like the person asking this question who actually go up to B100, but when they try to go down in month 4, their nervous system still is requiring more than 10 milligrams of B5. So this person actually went higher. So she went down, or he or she went down to 10 milligrams, then tried to go up, but was never completely pain-free. So one, that is not an uncommon situation. I want to explain the types of pain that are important here. The ones that are related to how you get paralyzed in sleep, which are things that are there when you first wake up. Like I step out of bed and the bottom of my feet hurt and I've been told I have plantar fasciitis. That means the bottom of my feet are inflamed. Like, why don't all of us have foot pain when we step out of bed? We are punishing these little jigsaw puzzle bones and tendons every single day. Miraculously, we step out of bed and we're not supposed to have pain. So why do I have pain in the morning? And oh, by the way, it goes away by 10 a.m. The pain that goes away early in the morning, but was there when you first woke up, my hypothesis is it's related to moving your feet or whatever part of your body it is that's bugging you, or tensing those muscles or tensing that joint inappropriately during the time you were supposed to be paralyzed and repairing that part of your body. That's one kind of pain. And you can adjust that pain by dialing the B5 in some circumstances, not all. There is now a second kind of pain, which is an inflammatory type pain that's usually associated with an increased sedimentation rate, an increased C-reactive protein, generalized joint pain, like it hurts to move my joints, that does not go away, that in fact is better in the morning, but worse as the day wears on as I use my body. is actually a separate system in my view. One, it has to do with the acetylcholine anti-inflammatory pathway, which is a separate pathway and is not really directly using the nervous system. It is using the vagus nerve, it is secreting T cells, and it may actually have a different B5 adjustment. If so, we're left confused and not able to get all the pains to go away. There is a third kind of pain that is probably related to the endocannabinoids. So there are lots of people in this country that are using medical marijuana and cannabinoids to treat chronic pain. The endocannabinoids are chemicals that our body makes that helps us with inflammation, with sleep, with appetite. They are normal neurochemistry throughout your brain and spinal cord and nerves that arbitrarily our US government decided that that chemical from a plant is something that should be illegal. That has delayed the research, but there are some kinds of pain that can be the whole limb. It's really not, in my personal experience, distributed between the joint and the muscle. It's more like my whole limb just decided to be horrifyingly painful. Those pains that respond to the endocannabinoids, that's all they respond to, because it is really an endocannabinoid deficiency disorder. So that's one possibility for this person. And there's yet another possibility, which is when you look up choline. Choline is something that comes from eggs and other foods, and it really does come from our food. But in people who are profoundly B5 deficient, some of them may be choline deficient as well. And the writings about choline suggest that choline actually in choline deficiency presents often as muscle pain. It has some special actions in muscle. Every time I ask my body to make acetylcholine, that is acetyl group from CoA and choline together, I'm using a molecule of choline. So anyone who's adjusted the Bs and can't get the pain to go away, the next thing you should try is choline. I do not feel that I'm an expert in it. I've used it in a few people. I really only feel comfortable doing that in someone who has used pretty aggressive doses of B5 and really can't get the pain to go away. And then the choline should be added. And it comes in a lot of different forms. It comes as acetylcholine, it comes in phosphatidylcholine, and you have to read about choline and decide what form you want to take. And I'm really not too sure about the dosing of it either. And then the fourth thing I would say is anybody who's trying to adjust these Bs, so therefore feels like they might be a little worse off in terms of their severity, I'm going to start recommending that you, once you get into month 4 of the RightSleep program, you start investigating your iron levels, because it turns out that iron is a player in making not only acetylcholine, and it can be a limiting factor, so that turns out there's a regulatory enzyme that affects the making of choline acetyltransferase that requires iron. That means if you run out of iron, no matter how much B5 you take or choline, you can have a perfect D level, exactly as I told you. The one missing piece might be iron. So if you start to run into a wall with using the things that I've told you about, the other thing to look for is what is your ferritin level, Ferritin. Ferritin addresses the storage of iron. There's a lot of controversy about this right now, but if you have known to have a low ferritin level, if you have had iron infusions, if someone's been telling you for the last 20 years that you're iron deficient, then this might be one of the players that I want you to add in month 4. The reason why you want to add it later is I don't want to add a bunch of things that you don't need. Iron has some issues. It's very controversial. Can we hurt ourselves with it? It's not completely clear to me yet about that. So I don't want to use it right up front. I want to use it in someone who looks like they need to add a few other things, and they have signs based on what's happened to them that they are profoundly deficient in several things. Just to back up a minute, you can be having meat, you can be eating red meat and still be iron deficient. And it is my hypothesis that when we lose our microbiome, one of the major responsibilities of those bugs are actually to take the small charged ions from the food and present them to the human body. So iron, iodine, copper, zinc, manganese, all of these small charged irons that are called minerals that we put in the multivitamin are all things that we have to get from our food. But it appears to me that the microbiome has been playing a role in presenting those in a way that allows the human to absorb it, particularly iron. So it's not uncommon to see 32-year-old men who do not menstruate, who do not have blood loss, now getting iron infusions. And there's no explanation coming from the hematologist. It is my belief, based on my clinical experience, that my patients started to be able to not need their iron infusions after they brought their bugs back. So that supplies a reason for someone being iron deficient over the last 10 or 20 years. Do not start to supplement iron if you have a ferritin of 100. Look to see whether or not your ferritin is low, get a level, start supplementing. I've been using just iron sulfate, just regular old, cheap as can be, iron sulfate. And the other wonderful thing is most people do not get constipated from it. Even if you had constipation in the past, once you get your bugs back, most people do not have constipation. And never take any of this stuff without a specific thing, a specific endpoint that you're trying to arrive at. Iron is not just good for you. Iron is good for you when you're deficient and bad for you once you've taken too much. So you need an endpoint, which is do your ferritin level again and probably get it over 100. And I'll be talking about things as they become clearer over time. So iron probably plays a big role in sleep. I haven't gone down the path of just putting in those two words yet, but I certainly wasn't aware of that. But I've definitely seen clinical response in some of my clients where we've used choline, we've used B5, and they hit a wall, and we add iron and everything gets better, and the requirement for the B5 goes way down. So I want to just circle back then at the end. Those are the other things that you might try. The other confusing part is there are many things about pain that I don't know about and I don't understand. So I can't really promise you that you will be pain-free by adjusting the B5. I can tell you that if it's pain that's new pain that happened to you at 6 months and wasn't there before and is there when you first wake up and is magically gone by 10 a.m., that pain is something you can use to adjust how much B5 you need. But there are multiple other kinds of pain that actually may not respond in the same way that I've talked about. In fact, most of my clients who had autoimmune disease or chronic arthritis have to just be patient and slowly get their sleep as good as they can, and then rely on their immune system slowly correcting over months and months and months of better sleep. And they see slow, steady improvement in their pain as opposed to a total relief of pain. That's why I can't really say this full explanation in the workbook.
All right, our second question. Do you have any experience with applying the RightSleep program to people who suffer with chronic Lyme disease? And if so, was there relief?
In my view, chronic Lyme disease is vitamin D deficiency and the wrong microbiome. So when you're looking at what happens with Lyme disease, you're really looking at an array, a population array. That population have people who are completely normal, have a normal D, normal sleep, a normal immune system, and get exposed to spirochetes. They will usually have some sort of manifestation. They may get just the skin lesions, they may get a little bit of arthritis, and they may actually completely defeat the spirochete disease and not have any other manifestations. That's what the immune system is for. The person who develops chronic Lyme disease is someone who is not a normal human. They do not have an organ of the body, the microbiome, and they don't have a normal D level to allow them to have a normal immune system. They've been told they have chronic Lyme because they have not responded to it in the way The first person did. This is the case for all infectious diseases. This is the case for COVID. So COVID kills people, not because the virus kills them, but because their own immune system leads to a cascade of events that finally kills them with fluid in their lungs. So it's never what's the infectious agent. It's always what's the infectious agent and what's the state of the immune system of the host. So in my view, the reason why someone gets labeled with chronic Lyme is because they need to do right sleep.
Does right sleep help recall in past situations or just going forward?
Good question. Good question. I can't completely answer that. I can say that there are certain situations, very specific situations, where our hippocampus, the actual memory machine, the videotape, is not on. Okay, so transient global amnesia is a sleep disorder. The person wakes up, they're fully functional, but their memory machine does not turn on. Those people never lay down the half an hour to the 5 hours or 24 hours that follows. They never lay down that tape. So they never can recover that memory. Okay, so that's the extreme. Then there's another way to look at it, which is, what you're asking is, do I have stored memories that are hidden away in there in my brain that recently I haven't been able to recall? And once I have a more fully functioning brain, will I be able to access them? Okay, one of the problems is that hippocampus, every time we sleep, every night, it takes the videotape of the last 24 hours and it sorts through it. And you decide when you're unconscious, what you're going to keep and what you're going to throw away and where you're going to put it. So things that you use every day, passwords, how to start my car, my kids' names, those actually not only get stored, but your pathways to find them. So putting it in the library is of no use if you don't have a librarian to help you find it. You have to also dust off the paths to get to these things you need every single day when you wake up, every night. So we have a hippocampus that's doing its job, but incomplete sleep, which means that the paths to find things become kind of dusty and really not as well connected as they should be. So then the next question is, what if I follow right sleep and I get to sleeping really, really, really well, and I feel like my recall of yesterday and my speed of function today are both just perfect now? So I have a speed of function, which means you ask me something, I can find the word and answer you at what we think is normal speed, which is really a global functioning of the brain. We have a hippocampus that stored everything that I thought was important last night. And then we have a third issue, which is, some of the things that I really like to be using, I can't get at. They're stored. I think they're stored because I know I took calculus, but I can't really get at it now. What I imagine is, as we sleep better longer, the brain actually knows that it's supposed to go and make those little paths again. And I've actually seen people have improvement in their memory over a longer span of time. So it's not impossible. It's just that I can't promise you that. And one of the things I want you to take out of these Q&A sessions is, this is not a recipe for success. This is a belief system that opens a path for you to follow for the next 20 or 30 years or longer. A way to think about what your body is doing in sleep. That means that you're constantly looking for, is there anything that can make it any better? Have I ever tried to do X, whatever it is? Does it make my sleep and my memory function better? So that's a great question. I think it's a complex answer, but we really don't have much else that's any good to improve the memory anyway. We'd all like to have the best sleep we could possibly have so that we can also have the best memory we can have.
Does RightSleep help people sleep better even when their spouse snores loudly?
Yes, that's an excellent question. And that is not something I expected. What I expected was when somebody says, oh, I don't have a sleep problem. Well, I do have a sleep problem because my husband snores. What I didn't expect was when you get that wife sleep better, she comes back and says, you know what? I woke up today to the alarm. My husband didn't even wake up. He was snoring so loud, I couldn't believe I was sleeping next to him. And I was like, oh, that's pretty phenomenal. But in actual fact, people with really good sleep, garbage truck can go by, the light can be coming through the window. That's why my general approach is if you're having to do behavioral modification and blackout curtains, I mean, it really means that your sleep is not the best it could be.
You say on your blog, quote, if your brain chemistry is off, you'll have trouble falling asleep, staying asleep, and getting the deep restorative sleep that you need, end quote. What causes someone's brain chemistry to be off?
You need to read more because that's what RightSleep is about. So watch more videos. The explanation for this is the reason why there's a website. So read more.
Do you recommend using an alarm clock, or should
No.
our bodies naturally wake up?
Well, we all need to use an alarm clock sometimes, but if at all possible, and you know, I'm retired, so I mean, I don't start anything till 11 o'clock. So I have this luxury now that I didn't have when I was working, that I can sleep in late. So if at all possible, you'd like to be able to let your body sleep as long as it wants to, especially on weekends or on days you don't have appointments. So it's not wrong to use an alarm clock. It is absolutely wrong to wake yourself up at 4 a.m. every day, because there is a certain span of time during which you are programmed to do REM, rapid eye movement sleep. And that is between 3 and 6 a.m. or 3 and 7. And if you purposefully wake yourself up so you can go exercise or swim or run or something like that, because you have 3 kids and you never get a moment to yourself, and that's the only time you can do stuff, you will actually make yourself worse.
Can someone be in the sun too long?
Yeah, then you'll get sunburned. I mean, that's why we have sunburning. That's why we have burning, to tell us, gee, being out here is potentially dangerous. That means we make melanin and we put it on our skin to allow us to spend more time. And interestingly, it's induced by being in the sun. So the normal situation at the latitude where I live is you start to get UVA light. Really, you have UVA light all the time in the winter. It's just, you know, it's cold enough outside that you got a coat on. And then in April, you start to have short sleeves, or you take off your shirt and you slowly build a tan. April and May, and then end of May, the UVB light becomes available, and you're already a little bit blocking it during the summer. So there were natural settings in which we actually slowly exposed our body to the sun. We have changed that so much that I can get on a plane and go to Costa Rica tomorrow and have my, you know, white, not tan skin out in the sun. And yeah, it's bad for us to do that.
How important are sleep studies for someone participating in RightSleep?
Excellent question. I have ignored them because most of the time, the physician that you're dealing with, or naturopath or other caregiver, already knows about supervised sleep studies. So the sleep study center where we go and we make you lie there and put on all these electrodes was our first approach. So most of your caregivers already know about that and may offer it to you, okay? But many of the people who are coming to my site have milder sleep things or have been told, well, you just don't look like you could have sleep apnea. And everyone can have sleep apnea. I can have sleep apnea. So having a supervised sleep study at a sleep studies center is the only way that you can actually record with electrodes on your head that you're in certain phases of sleep. Okay, but nowadays there is a whole huge range of ways to record your sleep. There are actually sleep tests that wrap around your head and that have electrodes on them, and sleep dentists, or in some states the insurance requires you to do a home sleep study with an oximeter on your finger and various electrodes on your chest with a thing wrapped around your head that can do a really close approximation of a supervised sleep study. And the trackers that we wear will not show whether or not we have obstructive sleep apnea per se. Some of them actually have included oximetry in them now. So the answer to the question, how important are sleep studies? It depends a little bit on what's been happening in your life. So in someone who has no obvious sign of snoring or waking choking or serious medical illnesses that have been associated with sleep apnea, hypertension, heart disease, diabetes, etc., people who don't have the warning signs of sleep apnea can still have sleep apnea, but you may want to start into RightSleep first. And the reason for that is that most people get turned off by the idea that, oh, I'm going to have to wear that CPAP mask. Okay, if that's the only actual therapy offered when you're going for a sleep study, a lot of us are going to go, I don't know about that. Okay, so this RightSleep then offers you another way to enter into getting your sleep better. Now, I want to just comment on the fact that I occasionally have people who start into RightSleep who actually had a sleep study sometime in the past, told they didn't have significant apnea. They get into the 8th or 9th month and they were better, but not all the way. And then they're waking up at 3 a.m. Their D is fine. Their Bs have gotten the best response they have. And then they see their ENT doctor, their ear, nose, and throat doctor, and the guy says, look, you've got a deviated septum and you only have half your nose to breathe through. And then they get their deviated septum surgery, boom, they sleep all the way through the night. So in my view, that means every single one of us has to acknowledge there's an anatomic basis that's in your nose, in your throat, that has to be addressed. Right now, I'm being evaluated. I had 4 teeth taken out as a teenager. Orthodonture still is doing that. But there is a new wave of orthodonture that says, no, the teeth are crooked because we are breathing with our mouth open. We are not enlarging our jaws enough by chewing correctly, so that we are taking out teeth, which is the wrong approach. When you take them out, the face gets narrower, the tongue, it doesn't have space, and it gets in the way of the airway. I would recommend to everyone that you read the book by James Nestor called Breath, B-R-E-A-T-H, and it covers this entire topic beautifully. It's not only about breathing and breathing methods historically and currently, but he also covers the change in the anatomy of the human face over the last 500 years, what the current sleep dentistry feeling about that is, how you can actually change how you sleep by changing the anatomy of your throat. So I would say sleep studies play an important role. More importantly, I would say sleep studies are a record of how well you did. If you have a sleep problem that is, I can't fall asleep, then stopping breathing isn't your issue. But once you get better and you do fall asleep and then you rapidly wake, that waking could actually be an anatomic problem. You've gotten so paralyzed that your airway is too small. So I think in most people, it's a little bit of the physiology that I'm specializing in on my website, and a little bit of the anatomic stuff that you should be looking for in sleep dentistry, in this book, Breath. So all of those parts usually play a role in most people.
One's a little more specific again, but I think it can be answered generally. I've been taking 5,000 IUs of vitamin D since last fall. My blood test shows I was in the upper end of the range So I stayed with it as I wanted to stay there. This summer, I've been outside a lot more than normal for the natural D and still taking the 5,000 IUs. My latest blood test showed my level fell significantly, and I'm under what I should be. I have been concentrating on my Bs because sleep hasn't been improving, and I am under a lot of stress lately. Could these be why it dropped?
I think this is a very good question to make the point that you have to, as soon as your sleep is goofed up again, you have to get a D level. And if you're starting the Right Sleep program, what you'd like to do is have it done monthly. There are some circumstances in which I think we actually use more D. I don't like to use the word stress when we're under stress because it's too non-specific. But I do think when we sleep more and make more repairs, I think I've seen people use more D. Now, this is kind of confusing because you haven't given us the specifics of the number and what month it was done. Okay, so if I actually have seen people get their range to be 60 to 80, and they're staying on 5,000. Let's say they've gone 15,000 for 2 months and then are now on 5,000 and maintaining. And I've seen it maintained in the winter, but it's slowly going down. But you haven't done any D levels, so you don't know that. So 5,000 really isn't the amount that you need to maintain. And then you do your D level again, and it happens to be the middle of the summer, and now it's low. One of the reasons why I have you do it every month is you really need to see is the current dose I've taken over the last month, keeping my level exactly the same, or is my level moving slowly up, or is my level moving slowly down? So you have to pay attention to that, because if your level drops by 3 points in a month, it'll keep dropping by 3 points over 6 months. And then your level can show up as, 52 in the summer, even though you've been taking 5,000. So there's a complex interplay there between two sources, the sun and the D. And to answer the question you asked, you're going to have to do your D every month for a while. Pay attention to what's happening. You must react to that D level every time you get it. You can't just look at it and go, oh, it was 58 last month. I'm on 5,000. And then you get another D and you say, oh, it's 56. That's close enough. Well, to be truthful, 58 and 56 are not 62. There's a difference, actually. Most people can tell the difference between 56 and 62. So if you do close enough, it's not like that's what I thought was going to happen. Oddly enough, most people really do feel different at a constant level of 62 than they do even at 58. So you have to actually pay attention, do it every month, and calculate, what is my stay the same dose in the summer with X amount of sun exposure? Was I using sunscreen? What hours was it? And what's my stay the same dose in the winter? And then you have to generate your own numbers. I don't want to point to stress and say, oh, stress made me use more vitamin D. I haven't actually seen that happen.
You stress on page 33 of the workbook that it's important to take all the Bs together instead of just B5. If increasing B5 incrementally is a way to fine-tune sleep improvement, assuming B12 and D levels are in range, is there ever a point after working up to a daily B50 and multivitamin that you can start increasing just B5?
Yes. So if you get over 100, so I'll have you go up to B100. If you have to go above that, and again, we're using physical symptoms that are related to acetylcholine production. If you have to go above that, then I'm kind of questioning, well, I don't think you have every single B is profoundly deficient. I think we're really using B5. So, and this is, again, experimental, and it doesn't answer all conditions, but if you go above B100, then I'll have you buy B5, and the lowest dose that it comes in a pill is usually 100 milligrams, and then have you cut it into quarters, and then go up by quarters or less. So you'll still use your multivitamin, to use a 5 milligram increase, but let's say you do 3 multivitamins and now that's 15 and you're about to go to 20, and you add a quarter of the B5. There's some fine tuning of this that I have some clients who have gone to 500 milligrams of pantothenic acid, and some of them have gone to 5,000 milligrams of pantothenic acid. That person needs to be coaching with me, to be truthful, because it's very complex and it's very daunting because there are lots of physical symptoms that come and go. So that's sort of a partial answer, but yes, that's what happens after B100 most of the time.
I went to a chiropractor who ran a hair analysis. He would like me to take supplements, many with a small dose of a single B vitamin. I know you said never to take one B without taking all 8. Since I am currently taking all 8 B vitamins for Right Sleep, will taking these other supplements mess up the program?
I think the way that's phrased, you have to depend on how much you're taking at the moment, okay? So if you're on the phase where you're taking B50 and a multivitamin, and you add another 150 of B5, you aren't going to feel good. B5 is a major player in this, but so is thiamine. So B1 is a major player in sleep. And most people, depending on where they are along this path, have to be very careful about how much thiamine they add. What I would suggest is you get to at least month 4, you're off the B50, you have the normal microbiome. Now you're doing month 4, 5, and 6, where you're managing your D and you're taking a multivitamin. And then you add these other supplements individually and you write down what you're doing and you see what happens to you. So you actually write down, this is what happened to my body when I added this much niacin or this much B1. And you acknowledge that they're on board. And then you see whether or not you get better or not. You know, as I have said in several other lectures, every single thing that's on my website is about clients coming back and saying, you told me to do blah, blah, blah. And then I did this and I felt so much better. And then I'm like, wow, that's cool. What did you do? So it's not like you can't yourself discover things that make you better. Also, you just keep in mind that each phase of doing right sleep, your biochemistry is slightly different. So when you're doing that during phase 4, 5, and 6, and you haven't gotten to needing extra Bs yet, you write it down and you acknowledge, okay, my bugs are back. I'm not needing extra Bs. I'm just on a little bit of my multivitamin. Here's my response. Acknowledge that if 3 or 4 months later, everything falls apart, you really don't know whether or not it's an increase in the need for B5 or whether or not your body decided it didn't need extra niacin or riboflavin or something like that. We should picture every single one of these supplements as a potential plus or a potential minus to how we feel and how we sleep. So then you take things away and you say, okay, did that make me feel better or worse? I don't discourage anybody from doing anything else their practitioner wants to do, but you have to make sure you're moving your variables individually and writing it down and paying attention to how you feel. Thanks for a great question.
Sorry about that. I recently bumped my B5 from 50 to 100 I'm assuming this is milligrams, MGS. I slept great for 3 nights and then poorly since then. Did I bump it too fast, or is my body telling me that it was great now, add more?
The reason why I have you do it by 5 milligrams is because this is very weird. So I can't really answer your question. I can say that what most people see is when they move by 5 milligrams, and some people move by 10 milligrams because they get impatient and their multivitamin has 10. If you go above what your brain wants, so now you're on B100 and you really don't know whether or not you need to go higher or you need to go lower. So that's why I have you walk up with every 2 days. Some people take longer than that. I'm not really sure. I'm going to do it for 5 days, and then I'm going to go up a little bit more and see what changes. And each person has a set of symptoms that change when they go up. So usually what I'll say is, as you're moving up by 5 milligrams, If your sleep or your pain gets better, it's a vote yes, this is the right direction. And if on the third day, everything comes back the way it was before. So let's say you were waking up at 3 a.m. and unable to go back to sleep. And the first night you go to 45, you go, whoa, this is awesome. I slept all the way through, and you stay on 45, another 3 or 4 nights. And by the fourth night, you're waking up at 3 a.m. and the same thing comes back. That's usually an expression of, yes, I loved 45, but I want a little more. I have no idea why it does this. This doesn't make sense to me, but that's what it usually does. Now, the problem with going up by 50 is you don't know that vote of going from 50 to 100 was, this is the right direction. And really what I want is 85, or really what I want is 110. So when somebody's really struggling and they've been at B50 or 60 for a while, and we really don't know whether or not they need to go up or not, sometimes I'll let them just go up to B100 and say, see what your body wants. To me, that means I want more, but it doesn't necessarily mean I want 100. It might mean I want 60, not 50. So I think it's confusing, and you really have to go back down, start at 55, go by 5 milligram increments every couple days. And for instance, if you, after this Q&A, you go back down to 60 milligrams and you say, I was much worse on 60 than I was on 100. If you can see dramatic differences, then you use that to say, okay, I was better around 100, but I wasn't perfect. So instead, what I'm going to do is I'm going to go to 90 and go down by 5 milligrams. There's no right or wrong way. You just have to acknowledge that I have people who are on 215 milligrams of B5, and 210 and 220 are not the same as 215. That is really weird, but that's what happens. So you have to know that that's the case, and your nervous system will be really picky once it gets close to where it wants to be.
In the workbook, you mentioned the use of sleep aids. Do you mean drugs like Ambien, anti-anxiety meds, or something else? I have taken SSRIs and they helped a little with sleep, but I didn't feel anything, so I got off of them. Is there another sleep aid that would be effective for somewhat long-term use? Already taking 10 milligrams of melatonin, and that doesn't help much. And I've tried valerian, chamomile, and other herbals. My doctors don't really want to prescribe sleep aids. They prefer the anti-anxiety stuff. Any thoughts on how I can educate them to get one prescribed?
So you actually know the answer to your first question. What are sleep aids? So SSRIs, so the thing that we've been taught as physicians is that SNRIs and SSRIs are less addictive. In actual fact, I think the SSRIs and the SNRIs have substantial proof that they are not positive for sleep. They actually inhibit our ability to get into REM sleep. The people who do the sleep studies and do read them say, oh, this person doesn't have any rapid eye movement sleep. They must be on an SSRI. Well, that's pretty sad. So it's easier for the doctor to prescribe those categories because they aren't afraid that someone is going to threaten them with giving a dangerous drug. Okay. Now, your next question was, how do I educate them? That is a very difficult point. And at the moment, physicians are highly controlled. Every prescription they write, they get faxes, they get emails telling them from the insurance company, you know, these are dangerous drugs, you shouldn't be prescribing them. And insurance companies are not clinicians, and they're not sitting in there with you, and you wouldn't want those actuarial tables sitting in the room with you. You want another human who will actually sit, listen to you, and talk to you and decide on a plan for you personally. So the reason why I have these things about drugs are not the devil. Drugs are just drugs. They're no different than vitamins. They're chemicals. They are not the whole answer for anybody's sleep. We have plenty of proof of that. They are a crutch, but if you have nothing else, than that crutch and treating your deficiency state, then you will not get better if you do not sleep. So I am spending my time trying to educate other physicians. Frankly, most physicians are not interested in this, and they have been brainwashed about D and about sleeping pills. So as to educating them, you might actually have to beg or say, I'm not sleeping and I really need to sleep. And you may have to find a physician who can't sleep, because the only people who are really sympathetic for this problem are the people who can't sleep. So the physicians who come to me are the ones who have sleep disorders and have already gone down the entire path of what medicine has to offer, and they haven't gotten better. So I'm sorry, that's not a very satisfying answer, but that's the best I have.
Okay, in perfect timing, we have one last question. In one of your podcasts, I believe you mentioned potential adverse links between low levels of acetylcholine inferring low levels of pantothenic acid and a yoga or meditation practice, which could place greater acetylcholine demand on the body, particularly for individuals who are in phase 2 or 3. Have you noticed any links between the changes in the necessary B dosage for ideal sleep and a noticeable increase in daily physical exercise demand on the body?
Great questions. One, I do have other colleagues who are still using huge doses of Bs that claim that when they exercise, they have to use more Bs, and they're adjusting their Bs based on physical exercise. I personally have not seen that myself, and I haven't had that as a routine answer from my clients, but that doesn't mean it's not true. Your second point, one of my client's brothers, the client is using a sleep tracker, so is the brother and his wife, and they decide to meditate before bed, and on their sleep tracker, their REM goes to like 0, which is like totally the opposite of what you'd expect. And her conclusion was, she's really, really smart. She said, oh, they used up all their acetylcholine meditating. So meditation, breathing techniques, all the things that we've come up with to up our parasympathetic tone, what we're doing with that is we're doing things that we can learn while we're conscious to purposefully turn up the amount of acetylcholine, or the parasympathetic side. Theoretically, if you're at the edge and you don't have reserves, you could actually use it up and mean that you don't have enough to get you your acetylcholine supply through to make REM. That's theoretical, but definitely possible. We know that REM sleep has the highest parasympathetic tone and therefore requires more acetylcholine. And those observations I only ran into after observing that most of my young, healthy females who've had a couple of kids, their usual pattern is of sleep disorder is they wake up, they fall asleep fine. They're terribly fatigued. They're taking care of all the kids, the household, and working full time, but they fall asleep fine. And then they wake up at 3 and they can't go back to sleep because they don't have enough acetylcholine to actually complete the phase of rapid eye movement that requires more acetylcholine. It's also interesting, since you mentioned B5, there are a couple of reports coming out of a lab that actually did studies of regional brain sections at autopsy in certain diseases and showed B5 deficiency in sections of the brain. So I thought I would be dead by the time anybody ever paid attention to B5 deficiency, but there are accidental studies that actually showed B5 deficiency in certain parts of the brain in Huntington's disease and in Alzheimer's disease. That means, oh, and the confusing part for this, the conclusory statements of these studies were, this is quite confusing to us because what it says in all the literature is B5 deficiency doesn't exist because it's in every food. So I actually wrote to this guy, but I didn't get any answer back. So that is a very confusing thing. The dogma is incorrect. And there are lots of people walking around with B5 deficiency in their brain, and it manifests in multiple different ways. I want to thank everyone for asking these questions. This is so fun for me. I really felt so conflicted about coming out of medicine. It's true, I'm not a practicing physician now, but I was really worried about giving advice on the internet. Since COVID, there are hundreds of doctors, thousands of doctors giving advice over the internet. And so I'm thrilled to have a platform on which to talk about these specifics. I've also begun to understand that no matter how smart the person is and how dedicated, this is a huge raft of really difficult ideas. And it's really hard to get your head around the entire set of ideas. Plus, we have new things that we're teaching each other over time. So I'm thrilled to have this opportunity to have Q&As for you. We're also going to be sending out some invitations to come to courses that are really for lay people that I'm really excited about. We're currently thinking about how to do that. So if people want to take a course that's much more designed for someone who is just really interested in this topic and may want to learn a little bit about how do I educate my physician? How do I educate the people I talk to about this? It'll be a course that's probably on the order of 4 hours long, a shorter course that'll be designed for people who are interested in that sort of thing.
Look forward to that. Thank you, everyone. We'll see you next month. Bye.